And I think this year we are excited that finally we had our second JAK2 inhibitor approved, Fedratinib.
That's right.
Can you also just briefly summarize the data with Fedratinib and your take on it?
Sure. So fedratinib was initially looked at in a phase 3 placebo-controlled trial called the JAKARTA trial. And this was also in intermediate 2 and high-risk patients. And here, the platelet count could be 50 or higher. So a little bit different from the COMFORT trials in that respect. And it beat placebo for both the 35% spleen volume reduction and the 50% TSS improvement at 24 weeks. That was, it was around 36% versus like 0 or 1% for placebo. So that was a clearly positive trial. Now, there was another trial done called JAKARTA2, which is important to understand in the current context since we are all using a lot of ruxolitinib frontline. So JAKARTA2 was a single-arm trial, actually non-comparative. These were patients who had received prior ruxolitinib, a minimum of 2 weeks, but the median was more like 10 to 11 months. So fedratinib was employed at the dose of 400 milligrams a day in these patients. There were 97 patients, and here they found that in the intention to treat population, they found a 31% rate of SVR and 27% rate of symptom improvement. Now, very recently, I think as recently as this year, there has been a reanalysis of these data because it was felt that we needed to look more stringently into why these people got off ruxolitinib. That is, did they really fail ruxolitinib? So this was presented at ASCO and EHA 2019, and they divided up the patients by, again, a more rigorous definition of relapsed after ruxolitinib, refractory to ruxolitinib, or intolerant of ruxolitinib. And here again, they found a 30% rate of spleen volume reduction with fedratinib and a 27% rate of symptom improvement. Now, granted, this was a slightly smaller subset than all 97. They had 79 in this analysis, but again, those numbers pretty much held up.
Absolutely. So where do you see the use of Fedratinib now? Like, where would you use Fedratinib in your practice as of today?
So, I think it's a valuable addition to our armamentarium in the Rux failure setting. To me, the benefits of ruxolitinib are so well established that I would continue to use that as my frontline drug of choice. However, if a patient fails, and now we have some direction as to what is failure, although nobody has really been able to define it very well, it's one of the most nebulous areas perhaps in myelofibrosis. However, with the reanalysis of JAKARTA2, we at least have a framework of what is failure. And yes, I would use it in those patients.